Welcome, everyone. We'll just get a moment. I see everyone is starting to join. I do just want to give a note as everyone is joining, you should be having a little pop-up come up on your screen about recording. We do just want to give a friendly reminder that this session is going to be recorded for educational and quality improvement purposes for NCUIH. So with that, I would like to get started for the day. So again, thank you all for joining. And again, if you are just joining now, I see people are starting to enter in. Our session is being recorded today. Before we begin, we would like to note that this session is recorded for the educational and quality improvement purposes. And NCUIH will be utilizing these recordings to continue to share and educate our frontline healthcare workers throughout this pandemic. Thank you all for joining. So we will get started. We'd first like to welcome you to NCUIH's first in a series of Project Firstline COVID-19 and infection control training series with our frontline healthcare workers and our special guests. We are very pleased that you could join us today, and it's our hope that this forum provides an opportunity for you to gain knowledge and foster best practices as it relates to infection control. During each of our sessions, we will hear from our experts as well as offer opportunities for all of you to ask questions in regards to the topics that we're going to cover. My name is Melissa Watson, and I am NCUIH's Project Firstline Public Health Project Assistant, and I will be your presenter today. If you do have any IT difficulties today, please, during our call, if you could chat directly to our IT and comms lead specialist, Victoria Humphreys, and she can assist you. Lastly, we would ask if you could please kindly enter your name, your UIO, and your external organization and any tribal affiliations into the chat box so that we can get to know each other and so that we also may count for your attendance. Next, for our agenda today, we have everything listed on our slide here. We will have a background on NCUIH and urban Indians to start. Then we'll go into an overview of Project Firstline itself. Our introductions will include NCUIH's Project Firstline staff, as well as the host and our subject matter experts for this session. We will then transition into our training objectives. And finally, we will invite Dr. Abigail Carlson from the CDC to provide a commentary, and we'll open the floor for questions. So if you do have any questions, please note that anytime you can look down on the bottom of your Zoom screen and we have a Q&A button, please feel free to click that section at the bottom of the Zoom screen again, and you'll be able to drop your question in there and our staff will be able to quickly respond with your answer, or we will also provide you with a note that we will hold it for our live question and answer session at the end. Next, we'd like to go into about NCUIH. The National Council of Urban Indian Health, or NCUIH as we call it, is the national nonprofit organization that's devoted to support and development of quality, accessibility, and culturally competent health and public health services for American Indians and Alaska Natives that are all living in urban areas. NCUIH is the only national representative of the 41 Title V urban Indian organizations, or UIOs, under the Indian Health Service, IHS, in the Indian Healthcare Improvement Act. NCUIH strives to improve the health of over 70% of the AIAN population that lives in urban areas supported by quality, accessible healthcare centers. Next, we have a short clip on urban Indians that we would like to share with you that NCUIH has put together. We'll just have one moment for the audio. Sorry about that.
Is audio not working? Oh, 1 second.
Just one moment, everyone. We'll get restarted with the video in just a second.
50s forced America. When you think of American Indians and Alaska Natives, do you picture this? Over 70% of American Indians and Alaska Natives live in cities or suburbs. Starting in the 19th century, federal Indian boarding schools governed by the doctrine, kill the Indian, save the man, took children away from their tribes and families, and the relocation era in the 1950s forced American Indians off reservations. Wait, so most American Indians and Alaska Natives live in cities? Do they all have the same culture and religion? Actually, there are 574 unique federally recognized tribal nations around the country, and many other organized groups, tribes, and bands centered in both rural and urban areas. And with more Native Americans living in cities than ever, urban Indians continue to celebrate their cultures and traditions. To learn more about how urban Indians are staying resilient and what you can do to get involved, follow the National Council of Urban Indian Health on social media.
Thank you, Victoria. So with that understanding, where are UIOs located? The map here portrays some of the UIO locations across the country for reference. We also are going to drop in the chat box as well a link directly to NCUI's webpage and the UIOs directly associated with NCUI. We have our 41 active UIOs, some of which who have subsidiary sites and are grouped according to the service types provided, which are full ambulatory, limited ambulatory, outreach and referral, and residential treatment. Each mark denotes a location of an urban Indian organization that's helping to serve approximately 70% of American Indians and Alaska Natives living in urban areas. These programs are culturally grounded and focus on providing holistic care, meeting the unique healthcare needs of the urban Indians, which is what we at NCUI are also striving to do for the UIO Healthcare frontline workers with this Project Firstline initiative. Next, we'll just have a short acknowledgement that we'd like to thank the CDC for their support, that Project Firstline is a national collaborative led by the CDC to provide infection control training and education to frontline healthcare workers and public health personnel. NCUI is proud to partner with Project Firstline. The contents of this program do not necessarily represent the policies of the AAHC accreditation body, OSHA, CDC, or HHS, and should not be considered an endorsement by the federal government. Next, we're going to move into our overview of Project Firstline. The overall vision of Project Firstline is being an unprecedented infection control training collaboration. The user-centered effort in adult learning designed for needs of the busy healthcare worker and public health workers overall. The vision is to have a culture of interactive infection control training and education flourishing in all healthcare settings, and to also improve the national ability to fight all infectious disease threats. So why now? Why now Project Firstline? We're approaching a year of being in a pandemic. We must slow and hopefully definitely stop the spread of the infectious disease threats, including COVID-19. Infection control works when it's done correctly and consistently. Project Firstline is here to ensure all healthcare workers' needs are met. Within Project Firstline, we do have a list of partners, which we can see on our next slide. And these are just to show the importance of this initiative. And it's just a part of the partners that are over 80 partners now working on Project Firstline. When it comes to NCUI, our staff, which is next, will show on here, our main core staff for Project Firstline. We begin with Dr. Kimberly Fowler, who's our Vice President of Technical Assistance and Research Center. Zipporah Fuller is our Director of Technical Assistance. Evelina Maho, our Public Health Program Manager. Dionne Apedjihoun is our Senior Project Manager. Tiffany Stark, our Program Associate. Myself, the Public Health Project Assistant. Victoria Humphreys, our Senior Communications Associate. And Alexander Zemo is our Statistician. So as far as the hosts, we have, again, myself, Melissa Watson. I am a Public Health Project Assistant with NCUI and Project Firstline. I have my master's in public health and experience in community outreach and education, most recently within nonprofits. At NCUI, I work with the Technical Assistance and Research Department, providing public health project assistance across the organization. Our co-host for today is Dionne Apedjihoun, and she has her master's in biomedical science, as well as a double major in biochemistry and zoology, with a graduate certificate in business management and a certificate in healthcare management. She is also SOFA certified clinical research professional. Dionne's experience is in quality control, public health, and clinical research, and she is also our senior project manager. Our subject matter expert today comes from the CDC. We would like to welcome Dr. Abigail Carlson, an infectious disease doctor from the CDC, as our subject matter expert. Dr. Carlson recently joined the CDC as a medical officer and is the infection control advisor and subject matter expert for Project Firstline. She advises the development of the curriculum and training modules. She also helps to provide strategic direction for the future of the collaborative, just to name a few things. We are grateful to have Dr. Carlson for joining us, and we'll be hearing from her later in the training. Next, just to touch on COVID-19 as a whole and where we are today, we do have a quick resource from the CDC that we will just listen to in reference to their tracking of COVID-19.
COVID Data Tracker is CDC's home for COVID-19 data. COVID Data Tracker combines data from across the COVID-19 response in one easy-to-use location. COVID Data Tracker's new landing page groups data by category to make it easier to find the data you need. The new statistics, or stats bar at the top, brings you the latest data on cases, vaccines, and deaths at a glance. Simply click on a category for more information. Each category offers data visualizations, cross-links to relevant pages, and many offer data downloads. New categories of data are added regularly, and most data are updated every day. Visit bit.ly/COVID Data Tracker for the latest data.
Also at the top here, we have a link that we've shared that will also allow you to see cases and deaths to date on an interactive map. Both of these excellent resources coming from the CDC. Next, our training objectives for today. So now we're going to transition over into our training. Today's objectives are understanding the Project Firstline initiative, which we have just done, covering the three main parts of a virus, discussing the differences between SARS-CoV-2 and COVID-19, as well as what makes COVID-19 an infection control challenge and how the CDC is recommending to keep disease from spreading. But first, we're going to get started with a little pop quiz. So we do just ask, there are two areas that you can respond, as you can see here on the top. Please go to pollev.com/wiredsun334 from your computer or browser on your phone, or you simply can text wiredsun334 to 22333. Once you've joined, please either text again to 22333, A or B, whichever you think is your answer, or you can enter it in on your screen. So as you can see here, as people respond, we will get a live response. So what is the vision of Project Firstline? A, infection control, or B, frontline healthcare and employment? We'll just give everyone a couple minutes to respond. And also, if anyone's having any trouble accessing the website, please check the chat box as well. Tiffany's also shared that in the chat box for you. Well, it looks like we're getting an overwhelming response for the correct answer of what is a vision of Project Firstline, A, infection prevention control. Well, thank you all. And just a forewarning, there may be a few more coming up for us. But next we will move on to the basic science of viruses. So let's start taking a look. First, we're going to begin with what's a virus. A virus consists of types of germs that make us sick by using a living thing, like an animal or people, to make copies of themselves to spread. They do this with a lock and key method. The virus invades the cells with a false key. It's not an exact match, but it's just enough to unlock the cell, allowing the virus inside to make copies of itself. Some viruses are also made up of three main parts. So the first part, if we go to the next slide, are the genes. The genes are the blueprint of the virus. They need to be read in order to make more viruses. The proteins, the next part, are what create a shell to protect the genes. The proteins are also inside the virus to help create copies, as well as outside to help move the virus throughout the body and move to others. Some viruses also have a third entity, an envelope, that is made of special fats that protect the genes inside. Some proteins do still stick out, though, to help the virus get around. These are the special fats. These special fats that are mentioned are going to be talked about again during our hand washing session, so we will revisit those in more detail. So knowing what makes up a virus, let's move on now to what is SARS-CoV-2 and COVID-19. So what's the difference? The first thing to understand is that we get infected with SARS-CoV-2 and we get sick with COVID-19. So let's take a look at each one of them individually. First, we'll go to SARS-CoV-2. For SARS-CoV-2, it's short for Severe Respiratory Syndrome Coronavirus 2. Shortened as SARS-CoV-2, the scientific name of the virus. It's the germ that causes the disease COVID-19. So going next, looking at COVID-19, this is short for Coronavirus Disease 2019. The fever, the cough, the difficulty breathing are just some of the symptoms that people infected with the virus SARS-CoV-2 present with. So based off of these questions, based off of these topics, let's go to pop quiz number 2. Again, same wired sun 334. We're going to text again to 22333. Genes, proteins, and an envelope are part of some viruses. True or false? All the answers seem to be coming in. I'm glad to see everyone paying attention. True is the correct answer. Genes, proteins, and envelopes are all part of a virus. So next, we're going to move on to the concept of infection control. So what is infection control? Next slide. According to the CDC, the infection control prevents or stops the spread of infection. Some types of infection control, especially during these times, are listed here, as you can see, from PPE to how we clean to obviously most recently, the vaccinations. Next, we'll talk about what is the goal of infection control. Understanding what infection control is leads us into the goal. Ultimately, it's to keep people from getting sick. Those people from our patients to coworkers, our family, our neighbors, our community, everyone around us. The goal of the CDC's IPC measures is they're creating to protect everyone within its jurisdiction, of course, which brings us then next to the project Firstline, ensuring that the knowledge is available there to help keep all these people as safe as possible. So next we'll go into what makes COVID-19 a healthcare infection control challenge and concern. Let's talk about the transmission of COVID-19. This transmission is unique. The symptoms and severity of COVID-19 vary among patients. Some are asymptomatic, where they show no signs, while some are capable of spreading before they even show signs, which are pre-symptomatic. The spread happens mainly from person to person through respiratory secretions, which leads us now into discussing how COVID-19 is spread. So going next, the proximity of the persons will increase the risk of the transmission, the closer that they are. The respiratory droplets form from coughing, sneezing, even talking or singing can land in the other person's mouth, their nose, or eyes, let alone being inhaled directly into their lungs. The closer persons are, and for longer periods of time, increases the risk of the spread of COVID-19. Also, ventilation plays a key role, as persons in an enclosed space with poor ventilation have increased risks as well. So next, we're going to take another quick knowledge break. Pop quiz number 3. A blank patient never shows symptoms. Is it A, symptomatic, B, asymptomatic, or C, pre-symptomatic? Slowly all coming in. 100% correct. Asymptomatic is the patient never shows symptoms. So overall, just to wrap up, some key takeaways. Clinical transmission and response features of COVID-19 that affect how we approach infection control. It's the way that COVID-19 is spread, how it makes people sick, and what tools we must respond that will affect the choices we make. And also, each element of infection control has a reason and a function. And again, we will continue to dive deeper and expand as we go through our modules over the next couple of months. Next, I would now like to welcome Dr. Abby Carlson from the CDC. It is my privilege to have her with us today. And also, please note, if you do have any questions still at this time, please feel free to use that Q&A section at the bottom of your Zoom screen to enter in your questions or comments. But Dr. Carlson, it's all yours.
All right, thanks everybody. I just want to thank everyone for being here today. It's really great to have this opportunity for us at the CDC to talk with you who are on the front lines, who have been working hard in this pandemic, as we well know, over the last year. And to tell you a little bit more about Project Firstline, which I know we've touched on before, but to really emphasize that this is a project we're putting together with a lot of partners, of which NCUIH is one very important one, to bring infection control knowledge to people where they need it, when they need it, in a way that's understandable and not jargony, not filled with words where you're like, I'm not sure what they mean by that. So we're really here to try to answer questions, to be here for concerns, and to provide you with tools that can help you or can help your colleagues. If you're trying to explain things to colleagues, to even patients, so that they understand why we're doing the things we're doing, why these things are recommended, that you have tools at your disposal to use. I really have left my comments very short at this point for a reason. I would love to hear questions and thoughts. I would love to hear about your experiences and the problems that you've been facing as you've been going through the pandemic in terms of infection control and your own workplaces and your own practices. So please don't hesitate to fill us in on the Q&A, to ask questions. I know we certainly can come up with questions of our own and talk through topics on our own, but please feel free to put your questions to us as well. So I'm going to stop there. And Melissa, do we have questions that you had wanted to ask, or that any of our panelists would like to pose? And audience, please, like we said, check the Q&A. Go ahead and put your questions in there, or the chat. But the Q&A box is probably the fastest, and we'll get to you.
Yeah, please don't be shy. And as Dionne noted also in the chat as well, you can feel free to raise your hand as well to ask questions, but let's please also just focus on the Q&A if we can. Dionne, do we have any questions also from any prior participants?
So we're waiting for those questions to trickle in, but I do have a question for Dr. Carlson. Dr. Carlson, can you speak to the new variants that we're hearing about coming out from South Africa and the UK and what that means for us? There's quite a bit of information in the media about doubling up on your masks, and there's a little bit of hysteria there. So can you provide some background on that? What does it mean for the current strain that we have, the variants, and what does that mean in terms of wearing PPEs for infection control? What should we be really doing?
Absolutely. So just to clarify some language things first, when people talk about variants, strains, or mutations, they're talking all about the same thing, the same process in the virus. So if you hear it called a strain in one place and a mutation in the other place, they're talking about the same thing. And this really goes back to what we just learned about what is a virus and how is it put together. So you'll remember that Melissa talked about how viruses have genes that work like an instruction booklet. That instruction booklet tells a virus how to put itself together as it makes copies of itself. I heard one person recently refer to it as the IKEA furniture booklet of viruses. And that's exactly what it is. And the problem is when the virus copies that book, because each time it copies itself, it has to copy the genes, the instruction booklet, but it copies it and it makes mistakes. Like a little kid who's trying to copy something from school homework and they get a word wrong or they spell something not quite right. The virus is exactly like that, and it's not good at correcting its mistakes. But the machinery of the cell that builds the virus doesn't recognize that it's a mistake and just builds it according to these mistaken instructions, how it's been copied out. And that creates a variant or a strain. And these strains, the vast majority of them don't work right, and they stay in the body and they never go anywhere. But every so often, it will come out of whomever's body it is created in and spread between people. And it's something that happens all the time in viruses. We know that this happens. We're very familiar with it, and we anticipated it. And it's kind of, it's too bad that we didn't say more clearly at the beginning that this was something that was going to happen, because we knew that this was something that was going to happen. It happens in viruses all the time. So that's the background of strains. That's how they happen. What does that mean for us and infection control? The good news is it doesn't mean that we have to change much of anything, if anything at all. The things that you do for infection control still work. And that's because a lot of those things that we do for infection control aren't dependent on no change in the virus. In fact, the reason we've used them in the past is that no matter what happens with the changes in the virus, those things are generally going to work. So your N95, for example, or your masks, they still block droplets the exact same way. And those droplets haven't changed. Soap and water still dissolves the envelope around the virus that takes those fats and breaks them apart. And even though the virus has changed a little bit, it hasn't changed to the point where it can prevent that from happening. And it probably never will. That's more physics than it is chemistry. And so soap and water will likely always work for coronavirus. And so, what the biggest point I would say is keep doing what you're doing and make sure you're doing it well. And that's the way to prevent strains from spreading. There's not an extra step that we need to do. It's just we need to do what we're doing and we need to do it well. The double masking thing has come up separately and yet at the same time. And so they kind of get mixed together, and some people are like, well, we should double mask because of the strains. But I would, in my mind and in principle, I would separate those out. And the reason is because even if the strains weren't new, even if we weren't having problems with new strains, we'd still be asking some questions about double masking. Right now, there's no sure data that says, oh yes, we absolutely have to double mask. We're learning things every day, really literally every day on this one. And new data is coming out every day as to just how good or how not good masking, double masking might be. What is the most important thing is that people are masked, period. And especially two people, if both of you are masked, that is very protective, and we know that. And that's source control. It's something that we've preached since towards the beginning of the pandemic. I won't say from day one, but once we learned enough, we took the position. And so the double masking thing, you're going to hear more about it. It's going to be a thing. We're still studying it. And I know it's a big question for us at the CDC as well, as to just how well or not well does it work? What should we recommend? But the important part is going to be getting your mask, making sure it fits, and wearing it all the time.
Thank you, Dr. Carlson. We do have another question in the chat from Sonia Tidnowski, and I will ask Victoria to unmute her microphone so that she could add some context to her question. And her question reads, I have some concerns with the media announcing that it would be best to postpone the second shot of the vaccine. Will CDC be correcting this message sometime soon, or is this something CDC is actually recommending? So I'll ask Sonia to provide some context regarding this. Is this regarded to the strains that we're seeing now, the new strains, or is this in relation to something else?
I think it's thank you for your time. I think it's a combination of both. Here in California, there's just been a lot of media attention around telling people to postpone it so we can get more first shots into people. And I guess from that infectious control position, it would be good to hear from CDC what their recommendation would actually be, so that we can also start sharing that with our health educators who are actually out there promoting vaccination, promoting testing, and getting that solid information out to our community members.
So this is something that is a topic of a lot of debate, and I'll be very honest, it really is outside of my area of expertise, because vaccination is just a completely separate sort of scientific division and process. And what I look at, and just this is for myself in my own hospital and how I think about it, I would follow the guidance of the public health officials in the place where you are. There's a lot of different and conflicting opinions about this. And I'm not aware of any one CDC position on it. but it also is kind of out of my sphere of influence right now. And so I don't know all of the discussions that are going on about it. Certainly, you know, there are two goals. One is to make sure that everybody is vaccinated as fast as possible and as safely as possible. And two, to make sure that that vaccine works correctly for people. And that's those two questions. Are we doing it quickly? Are we doing it safely? And is the vaccine going to work if we do it this way? Are the big questions that have created this discussion about, you know, which pathway is better to go down. So I'm sorry that I can't answer that question in more specificity. I wish I could, but I think, you know, like I said, for myself, for my own healthcare facility before I came to the CDC, and even now, what I would say is, whatever your local health department is saying their strategy is, follow that strategy and work with them on that.
We're
Thank you,
following
Dr.
what the
Carlson.
IHS is telling us, and I think that right now is the best policy, given the fact that with the 2 shots, we are able to have the 95 or 97% protection. So yeah, I appreciate that. I just thought I would ask the question, see if there was something new developing, because it's getting more and more media attention, but no problem. Thank you.
Yeah, no, of course. We all agree it's a wonderful question. It's an important question. And I think we're struggling because the science to answer it isn't quite there. So we have to make some good educated assumptions and try to figure out the best path. So yeah, it's a tough one. I think there will be more clarity within the next couple of weeks and months, but you know, I think deferring to the people who have the shots as to how they're going to distribute them. More and more, I'm seeing some good coordination amongst the groups for coming up with plans, and I think things are going to get sorted out here as we move along. But I recognize the struggle.
Wonderful, thank you.
Thank you, Dr. Carlson. And I know that this is not your area of expertise, but if you could shed some light on some of these questions. I do have another one. How many people in the US need to be vaccinated in order to achieve herd immunity? Do you think we will be able to achieve that? And if so, when, if at all?
Yeah, so it's a tricky question, and a lot of different numbers have been floated about. And, you know, and it's really dependent upon things like disease dynamics and how much things spread, how fast they spread, how well they spread. And so it may actually be different for some of these different variants as well. What I would say is the number that people are floating around is about 70%, and that's 70% of vaccinated or otherwise immune, so they've gotten the disease and they've recovered. But I think that number is sort of a guess as to how it will be. Will we ever get there? I'm not sure. I really am not. And you know, a lot of this has to do with people's desire to get vaccinated, their willingness to get vaccinated, their concerns about it. That doesn't mean that the pandemic won't end. I think that, you know, the idea that herd immunity is what is going to end the pandemic is a little deceptive. It's not necessary in order for a pandemic to stop. That doesn't mean that coronavirus will go away entirely. I think many of us believe that it will become like the common cold, actually, and which a lot of its family members, other coronaviruses, are common cold viruses. So at some point, we will make that transition. The benefits of immunity are obviously less people die, less people get sick, and the pandemic may end faster. And so that's really the push beyond vaccination. But we are not dependent upon vaccination for the pandemic to end. So that's kind of the answer of a question you didn't ask, but to answer the question you did, the herd immunity question is still kind of up in the air, but the estimate that I've been seeing is around 70%.
Thank you, Dr. Carlson. I do have another question for you, and this might be right up your alley with infectious diseases. Is there another virus type on the horizon that isn't as front and center as SARS-CoV-2 in our community that we're not aware of?
Yeah, so there's kind of two thoughts I have on that. One is that no, there's not really a virus out there that we have our eyes on right now that we're like, oh my goodness, this is going to become the next problem. And so, in that sense, I'm more concerned about all the other infections that we haven't been paying attention to, right? So we're seeing a lot of antibiotic resistant infection rates increasing because we've been paying so much attention to SARS-CoV-2. We were worried about flu season. Thankfully, the things that you do for coronavirus seem to prevent the flu as well. So we have not had a flu season of much substance at all, which we're incredibly grateful for. But that if flu is going to come back every year, it kills 30 to 60,000 people approximately every year. And so that too is something that we're concerned about. So I think, there's one perspective on this that says there's not really any new emerging virus on the horizon. And the big concern is going to be all these infections that we haven't been paying attention to that we know exist and kill people, on a yearly basis. I think the other part of that answer to the question is there is always something on the horizon. So we have come over, I would say, the last 20 to 40 years to a very, of a much better understanding of the ways that diseases happen and how viruses in particular, but also bacteria and funguses, how they change in ways that suddenly make them much bigger human problems. And this, in fact, is very linked to our understanding of the connections between humanity and the environment and animals, right? Which in Western culture has not been a big theme in the past, though it certainly has in many Native American cultures. But this idea of what we call One Health, right, has become much more something that we're paying attention to. And that interaction between environment, animals, and humans is actually part of what we look at when we're looking for new diseases that emerge. And so, the answer is also sort of, we're always anticipating that interaction between the planet, animals, and humans is going to make new viruses, new bacteria, and unpredictably, or with some, good thought and tracing of things, we can possibly predict or anticipate that another virus or another bacteria will come out and cause problems in the future. And I think you're going to continue to see this. I mean, we've seen Zika virus, we've seen, the Ebola outbreak, we have seen the original SARS, and all of that is in the last 20 years, right? So this is not the end of things. It's just another step in it. It just happens to be an incredibly severe pandemic in ways that most of these other things are not. So that's my lecture on One Health for everybody.
Thank you, Dr. Carlson. Another question for you. Does the CDC have recommendations for appropriate messages to children or teens about safety at school and in crowds?
Yeah, so we have a whole team working on school. Crowds is definitely a general one, but messaging to teens and messaging to children is really sort of in the school safety and group. I would encourage you to go and look on the CDC website for specifically stuff related to schools, because that tends to talk about the right age groups. There is a lot of the same stuff for adults that there is for kids and teens in particular. It's been hard to message the idea that you should not hang out in crowds to teens, as you guys probably well know. But it's the same message for teens and adults, that friends can have coronavirus and you need to keep a mask on and stay socially distant. Whether that's working or not is a harder question and a more complicated question. But I would say the messaging that is on the CDC website for schools would be the first place that I would go. And they have tried to translate things a little bit to make the language plainer for kids, and with some good illustrations and things like that.
Thank you, Dr. Carlson. So I have 3 questions that appear to be related to each other. So I will go ahead and ask them a 3-part question, so to speak. Is it true that ibuprofen or aspirin should not be taken before receiving a vaccine? Another person wanted to know which of the vaccines are better for COVID-19. And the last question is, someone is allergic to chicken or egg and would like to know what shot is better for them to take. And I gather we're comparing Moderna and Pfizer. I know that Johnson & Johnson has their eye on the ball as well with a single shot, but I think for the purposes of this, we're looking at Moderna and Pfizer.
Right. So can you repeat the first question again?
Absolutely. They wanted to know if they're hearing that with regards to ibuprofen or aspirin, that it should not be taken before receiving a vaccine. Is this true?
Yeah, so I think that the data so far are not entirely clear, but in general, we're saying to avoid it. There's not a recommendation like you must or must not. And in fact, after the vaccine, if you're having discomfort, you can certainly take a painkiller if that helps, if you find that ibuprofen or Tylenol work for you. There's no outright you must not, or you must do one or the other. There's some concern, and I think so far that concern is mostly in theory, but there's some concern that ibuprofen or Tylenol might decrease the effectiveness of the vaccine. What I would say is kind of the simple advice, but it really is true, and it holds true in this case. Talk to your provider, talk to your doctor, make sure that, for the medication that you're taking for the conditions that you have, that taking ibuprofen or acetaminophen is a good idea or not a good idea. That's an assessment that really is a person by person basis. So I know it's another one that I can't officially or unofficially, I just genuinely don't know that there's a clear answer one way or the other, but I would say it's a decision to make with your medical provider as to which one would be best for you. And then, sorry, the second question was about which vaccine is better, correct?
Correct.
So my honest answer is I would take any vaccine I could get my hands on. They're all very good. They're all very good at preventing death. They're all very good at preventing severe illness. And they're all very good at preventing most mild illness as well. And so I would say I wouldn't necessarily have a preference for any one vaccine. The tricky part, we always talk about efficacy. Well, this vaccine is 95% effective or 96% effective. But you have to remember it's effective at doing what, right? So the Pfizer and the Moderna vaccines, they both have very close efficacies. I think one is 94 and one is 95. If their effectiveness is their ability to prevent severe disease. So it's not that you won't get sick with those vaccines. 95% of people won't get sick. It's not that. 95% of people won't get severe illness. The Johnson & Johnson vaccine, I'm less clear about what their efficacy number has ended up being. And I think it kind of depends. They've reported a couple, so it depends on the efficacy of what we're talking about, but it's still good enough that it's worthwhile. And I like to give a good comparison. And so one of the best comparisons I can give is with the routine shots that you give. So for a mumps shot, for example, it's about 95% effective as well in preventing mumps, right? So pretty good. An influenza shot, somewhere between 15 and 60%, depending on the year and the strain of influenza we're talking about. And then most vaccines are in between those two extremes. So just because the efficacy is low doesn't mean it's not worth taking. I think it's worth taking any vaccine you can get, and it doesn't mean that you won't be able to get a different vaccine in the future. And it doesn't mean that the vaccine is going to be wrong for you if you get the one that is 70% efficacy. So I wouldn't judge too much on that. I would say whatever is available to you, take that one. The data is actually really good. It went really fast, I know, and it's kind of frightening that way, but in all honesty, they followed the book. They just did it really quickly. And so in that sense, I have no preferences to vaccines. And then the good news for the egg and chicken allergy sufferers, there is no egg in this vaccine. It is not like flu. It's not made like flu at all. And so, so you do not need to worry about egg allergies at all for Pfizer or Moderna. I'm not entirely sure about Johnson & Johnson, but I'm like 75% sure that you won't need that. Best thing to do, ask about it for wherever you're going to get the vaccine. But for sure for Pfizer and Moderna, not made with eggs, don't need to worry.
I just had one other question that just popped up. Are there any allergies to be aware of prior to getting or deciding on a vaccine? Again, from Moderna or Pfizer?
Sure. So the answer is your own allergy history is important. And it's important if you've ever had what's called anaphylaxis. So if you've ever had swelling of the lips of tongue or difficulty breathing and had to go to the ER or even had to get intubated, if you needed an epinephrine shot in your thigh or your arm because you were having a bad allergic reaction, those are things to tell the people who are going to vaccinate you. Allergies that were, say, just a rash, say you took an antibiotic and you got a rash, but you didn't get anything else, nothing else happened, they're gonna watch you, they'll watch you afterwards, but the risk is much lower than if you've had anaphylaxis before. And even people who have had anaphylaxis, I don't think they're listing it as a full contraindication, but again, something to talk about with your doctor about whether or not that's something you need to do. So it's not a specific allergy, it's whether or not you've had allergies, period, and especially the kind of allergy that causes you to have difficulty breathing or swelling in your face and your tongue.
Thank you, Dr. Carlson. So that's our list of questions for today. If there are additional questions that pop up after this training event, feel free to write us at ipc@ncui.org and we will get an answer to you. Thank you, Dr. Carlson. Back over to you, Melissa.
Thank you. And thank you again so much, Dr. Carlson. It was an absolute pleasure to have you with us, and we are very thankful for you. So
It's a
next,
pleasure to be here.
oh, of course, so come back anytime. Next, we just want to list some resources for you all as well. We want to thank you all for your participation. In closing, we would like to share with you our resources for today's presentation. We have our links to the CDC's video logs, as well as those that are, that are hosted by our very own Dr. Carlson here on today's topics. They are also available, as well as many more to come. So what's next? Coming up in our sessions, we have transmission and source control. So we would like for you to join us on our next webinar, which will take place on Thursday, February 18th at 2:30 p.m. Eastern Standard Time again. Our topics will be transmission and source control. We will cover the transmission of COVID-19 and how personal protective equipment, or PPE, works when it comes to infection control and COVID-19. Remember, how well PPE works depends on you, if you use the right equipment, the right way, at the right time. Next, we also want to list up our upcoming events for NCUIH. For Project Firstline, as I mentioned, February 18th is our next webinar. Our Champions Echo sessions are monthly. Our next session for that will be March 4th at 2:30 p.m. And CDC Project Firstline partner activities are also open. They will be notified for you in our NCUIH newsletter and emails. SUNY COVID is having their second mental wellness community of learning. That will be February 16th at 1 p.m. And we also have an upcoming NCUIH accreditation series that will come out in the spring. The accreditation facilities covered will include AAAHC, CARF, and NCQA. Registration for that will be coming soon. Lastly, we have our post-knowledge survey, which has also been dropped in the chat for you, that we are asking for you to take a few minutes to complete. Once our webinar does end, you will be prompted with the questions automatically. We will also share in a follow-up email to all participants as well. Please remember, your feedback is key to developing an effective training program on infection control. Let us know what other topics you'd like for us to include and your thoughts on today's session. So overall, thank you all again for your time, and we look forward to seeing you next time. Have a great day.